Thanks for inviting me. Today I'm going to talk about something that's dear to a lot of people's hearts. It's homelessness, developmental disabilities, and a bunch of other things like brain injury and dementia, and sometimes the overlays between all of these, and how that might impact individuals functioning in the community, and in some cases explain why individuals are so disabled and homeless. And you can slow me down if I need to. I'm a neuropsychologist by training. I work at CAMH as one of the neuropsychologists, and I'm also working with a family health team that's associated with Seaton House. And I'm also the president of the Ontario Psychological Association, so if you need to get psychologists in your teams, let's talk. I think for me in particular, in the past couple of years, it's been a very interesting ride in the sense of helping individuals navigate the system. I'm still learning to navigate the system. It's complex. It's very annoying. It's a lot of roadblocks, a lot of red tape. And what I'm hoping to achieve today with you is talking about some of the successes we've had to increase access, to increase the speed at which the system responds to some of these individuals with very great needs. I should have a remote, and hopefully this is going to work. And it does. So why am I here today? And I just lost my stick. Two reasons in particular. I always like to add advocacy to everything I do. So if I can convince you to get mobilized and do something for some of the most vulnerable patients that I know you guys see, and perhaps some of them are homeless, let's get talking about that. In my practices in the past 4 years, the one thing that I noticed the most was all the missed opportunities along the way for the clients I serve. And I want to give you an example. In one of the women's shelters in Toronto, I saw a woman. She was now in her 40s, very heavy story to tell. And one of the first things she told me is that at the age of 7, her father hit her so hard that she fell over a pier and hit her head on rocks below in the water. So they were on a pier somewhere, and something happened. Dad was violent. She was hit hard. She fell, had a brain injury. Didn't know this, but she clearly had a brain injury from description. Lost consciousness, was brought to the ER, and was in the hospital for, I believe, 3 or 4 weeks. So we're talking here something pretty severe. And what she recalls after that is she failed grade 8, 7 or 8 times after that. So as a neuropsychologist, one of the first questions I ask is, where was the system at the age of 7? We can't always prevent bad things from happening, but we can actually, the system could actually do something to intervene a lot sooner. So this is a person who basically navigated through life for probably a good 30 years before seeing me. According to her, I'm the first one she told about her past abuse in childhood, physical, sexual, and neglect. I was the first one she talked about her brain injury, that now she understood why she had so much trouble in her life. And she also told me that nobody really helped her along the way. She was from the eastern provinces, but she didn't get supports in schools, according to her. I'm not sure how accurate that is. She didn't get the support she needs, that's for sure. And she basically became homeless very early on, so at the age of 17, 18. She managed to hold a job once in a while, but struggled quite a bit throughout her life. So by the time I get to see her as part of a project I'm going to talk about today called Bridges to Housing, we're already talking decades later where we've identified her with a developmental disability secondary to a brain injury and severe neglect and trauma in childhood. So cognitively, she was not doing so well. Adaptive functioning was really poor as well. She barely could read and write. And by definition, that is an intellectual disability. Again, I'll be talking about that as well. Maybe not the classical conditions that you would not normally associate an intellectual disability with, like autism or Down syndrome and some other genetic disorders. But she went through life with no supports, struggled, And the system, in my opinion, should have done a way better job at helping this individual. We could have done so many interventions throughout her life to prevent the homelessness, to prevent the ER visits, to prevent all the heartache she's been going through. And so that's the type of stories I want to talk about today, and why advocacy is so important for me. I also want to discuss some of the things you can do in your practice moving forward. If you, I guess I can just ask you, how many of you here deal with homelessness in any way, shape, or form? Either as, preventing your patients from becoming homeless because you're afraid that something's going to happen, or you're responding to individuals. So a few hands out there. It's an interesting kind of job, interesting work. The case workers we work with struggle a lot because they're trying to navigate a very complex system, and they don't always know where to go. And before 2 years ago, when we said the term developmental disability, I just had some glazing eyes looking at me. Nobody knew what I was talking about. No, it's schizophrenia. No, it's so many things other than that. And then when you tell them there's an actual $2 billion program associated to support persons with disabilities, people start to ask questions. And what boggled my mind so much is, why are we only talking about this now? Why aren't homeless persons getting more supports? So at the end of the day today, I'm going to be talking about ways to identify folks more easily, how to speed up access to care, all the things on the front lines that can be done. And I'll talk a little bit about some of the tools that are available to you that could help you navigate these things. Again, I mentioned that I'm working at CAMH. This is an article we released a year or two now ago for Bell's Let's Talk, and at the time they're starting to talk at a provincial level about the homelessness panel forum. The provincial government wanted to do something about chronic homelessness and homelessness in general, and the Ontario government started funding projects, and NCSS had the housing task force that was put together. So all this experience has led to an application to the housing task force that was successfully funded. Coming back to homelessness, when we talk to professionals, frontline workers, they will talk about schizophrenia a lot. Everybody knows about psychosis, schizophrenia among the homeless, but in reality, it's not as big as people might think. My colleague Stephen Wang basically did Dr. Wang did some studies around that. It's only 6 or 7% of the homeless have schizophrenia. It's way higher than the normal population, but that doesn't explain 92% of the reason why people are disabled on the street. Brain injury, according to him, again, 50% of traumatic brain injury. Huge, about 12 to 15% more to moderate severe folks, causing disability. So, and that, like when you start adding a layer, it becomes even more interesting. Crack use, drug use, very big. We know that crack is associated with stroke frequently, and frontal lobe changes and functioning that might affect somebody's ability to self-regulate, problem solve, and chronic alcohol abuse. We have something called the Managed Alcohol Program at Seton House, and that program is there for those who like to drink rubbing alcohol, for example, on a daily basis, right? We want to help them with a harm reduction approach to help them use something more that's healthier, I guess, in a way. So we give free wine and free beer to patients, and whiskey, because we know that if we don't, they're going to go to the pharmacy and just get a bottle of rubbing alcohol and drink that. And that has the toxic effect on the brain, on function. It's not a pretty thing, and the poor liver as well, right? And we even had one, I'm going to talk about another case today about a gentleman we actually discovered who had FASD, who was in his 30s now, a native man who basically was homeless in the city, but because he wasn't able to read and write, he'd go to the pharmacy sometimes, pick up a bottle of rubbing alcohol, but sometimes he'd mistake it for peroxide. And he would drink peroxide because he couldn't read the labels. Or he'd see the bottle, and to him that was enough to think it was rubbing alcohol. It had teeth decay, obviously a lot of gastrointestinal issues. So these are the type of clients I see, again, missed opportunities. Why is the person in front of me 20, 30 years later in a shelter? And one of my physician colleagues did a little study as part of the MAP program, and the average age of the person that died that year, there's a lot of them, was 52 years. So, that's pretty, that's a shocking statistic. It's not published, but it's basically internal data that show that, you know what, we could do a lot better. So 52 years of age life expectancy for a lot of the homeless guys. Poverty itself, we're realizing now, even affects things like intellectual functioning. So severe poverty, there was a great study in India where they actually studied they had some group of farmers there that part of the year they're the richest people in that area. Another part of the year, when money runs out, they're the poorest until when they can actually cultivate their farms. And some researchers actually studied how their brain functioned while they were severely suffered from severe poverty or when they were rich. And we found big discrepancies in cognitive functioning. So as I work with the homeless, I have to be mindful of that. So people's cognitive functioning could be impacted by poverty. Hence why Housing First is so interesting, because let's get them housed, let's get them funded and supported and getting nutrition and like food in their fridge, and then let's figure out what's going on as well in terms of health and so on. So sometimes it has to do in parallel, but poverty is a big issue. My question in the past 3 years, is this the full story? Or is there something more missing? So every step of the way, every year, I'm very picky about what I do in my practice. So I spend probably a couple of weeks every year to analyze all the data coming in. We want to make sure we're actually doing a decent job at diagnosing, picking up the right things, referring to the right system. So we do program evaluation every year. After my first year, I was expecting just to see persons with traumatic brain injuries, because I'm a neuropsychologist and that's what people think I do, right? So they refer to me based on traumatic brain injury. But because it was so complex, the picture, I got such a varied picture. Even developmental disabilities or neurodevelopmental disorders, they were referred to me for. Even I counted for 6% in the first year. We weren't looking for them, but 6% of the population I see had severe neurodevelopmental issues. TBI, stroke, and so on. Mental illness. So basically, one of the key findings I keep going back to is, of all the patients we'd seen that first year, only 85% had an issue. Only 15% did not have anything neurological going on. And only 20% at the time did not have any mental health issue, that how we classically define it as more the PTSD, trauma, schizophrenia, and so on. Substance use, 53% alcohol, 21% everything else, drug use and so on. And again, only a minority weren't using any kind of substances. And when we put it all together, when substance use, mental illness, brain disorders, everybody had something. All the homeless individuals we saw had something, a combination of one thing or another. And that had an impact on their ability to function. So homelessness is not about, oftentimes, laziness or inability to do things. It's really about a disability of some sort that we need to get better at figuring out what's going on. On this slide, I'm only going to focus on one thing. 90% of the folks we're seeing who are homeless have a cognitive disorder of some sort. 90% have a cognitive impairment. And when we go a little bit more deeply, 80% had 3 or more cognitive impairments. So we're a lot of like either memory disorder or executive dysfunction. They can't plan, they can't reason. So, and 61% had a global cognitive dysfunction where they were impaired across the board. And so we're expecting them to find work. We're expecting them to go back to their lives. But when you have permanent brain disorders affecting their ability to think and function appropriately, what is the expectation and what kind of rehabilitation can we provide? We have to remember that people who are homeless do not have access to what we have access to in terms of rehabilitation. You have an accident in your car today at some point, you're going to have access to insurance, you're going to have access to OTs, you're going to have access to psychologists, you're going to have access to Mercedes of care. But if you get assaulted on the street and so on, or you fall and you break, and you don't have social supports, oftentimes you become homeless. I had a gentleman who was actually a diplomat under Brian Mulroney, master's level education, but developed some sort of dementia and ended up being homeless. So anybody can actually fall between the cracks. So what's wrong with the system? if I let you actually answer that question for me, you would probably be here for days. From my perspective, again, for really dealing with severe poverty, severe homelessness and so on, there's a lot of problems. We did, and again, anybody here deal with housing in any way, shape, or form? Long-term care, all these kind of things? We thought it was a great idea to bring in the CCAC one day and the LINs and the shelter system to actually problem solve some of the reasons why people were homeless. And we had high hopes, right? We got them in, we'll get them housed. And the reality is when we start breaking down, we had this 3 to 4 week intensive process where we got psychiatrists, neuropsychologists, social workers together and frontline staff to really identify individuals. And we went deeply into 120 patients' files, assessments, and so on. In theory, 42 of the 120 should have been in long-term care. So why weren't they? So we started asking the question. And the CCAC was great. I mean, they were basically working within their own frameworks and so on. And the reality is only 7 out of 120 was going to receive get an application done for CCAC. But the worker basically told us, you're not going to get them housed because of their addictions or severe behavioral issues. So again, we're back at square one. So we bring the LINs in, and it's not a criticism, I think it's a system flaw. We bring the CCAC, we bring a lot of frontline agencies together to problem solve. But we're trying to make people fit into a system that's not developed for them. We have a lot of folks who are complex, who have a lot of comorbidities, and we're trying to make them, fit in the system. Developmental disability is one of them. So if we have an individual with a developmental disability, but on top of that they have an addiction or a severe mental illness, is the DD world going to take them on? If they have a brain injury and developmental disability, is the ABI network going to take them on, or is it developmental sector? If you have an addiction, the mental health and addiction overlay, who does what? We're so siloed within our own kind of worlds that when somebody has multiple issues, that person falls between the cracks. And this is the reality of the persons I'm seeing here. If you require a managed alcohol program, but you have a developmental disability, there's nowhere for you to go except the shelter system. And that's why we found folks who've been at, and I'm going through CAMH as well, 10 years at CAMH, nowhere else to go. 10 years in shelter system because there's nowhere else to go. And I'm going to show some data. And it's frustrating for me because they should have a place to be. It's frustrating for me because CAMH is one example that he's been at CAMH for 10 years but never saw a psychologist. Yet the psychiatrist basically saying, and I'm CAMH, I'm probably going to fire by the end of the day, but that's okay. It's good, we're working at it. And the psychiatrist saying, I think he has a developmental disability. Why has he been at CAMH for 10 years and why hasn't he been diagnosed yet? And trying to highlight all the flaws in the system and the red tape everywhere and trying to overcome that, that's the one thing I'm trying to do really hard. So what we've learned today, system's flawed. There's a lot of issues. We need to fix them. I'm summarizing my own things here, but I mean, ultimately is that there's, people have difficulties in life. There's no system adapted to meet their needs. Bridges to housing is another exciting things we put together. It came about kind of randomly. Some individuals at the City of Toronto saw a posting about the Developmental Disability Housing Task Force. Says, you know what, maybe we have people with developmental disabilities in the shelters. They hadn't talked to me yet. And they got together and said, well, let's talk to Inner City Family Health Team. Perhaps they have folks who have fallen through the cracks. I said, yeah, cool, let's work together. Put this proposal together. We get $1 million over 2 years to look at the issues. And oh my God, we saw so many issues. But it's great because it gave us an opportunity to innovate and to reduce the frustrating wait times that we see in the different streams. This is a developmental disability focus, but at the same time, the same learnings apply to brain injury and dementias. So that's why I'm so excited. So everybody here knows the DSO? I should ask a question, who doesn't know the DSO here? Nice, it's a nice program, right? There's the Surrey Place has done some great work. There's Community Living Toronto, a lot of agencies dealing with. So there's a lot. I admire what you have in the developmental sector, because I compare it sometimes to long-term care and brain injury, and you have way more in terms of resource and services, but you'll probably tell me it's not enough sometimes. At least from my perspective with the homeless, every time I send somebody with a brain injury forward in their system, they don't go very far very quickly, but at least with DSO, we can get passport funding. We get some adult protective workers to work with individuals and help us move that individual along. So I actually admire your system, believe it or not, compared to all the other things I'm working with. Everybody here knows what developmental disability is. Somebody who doesn't know? Basically, from my perspective, this is again medical, developmental, like diagnostic stuff, but what we're looking for is very broad. Does that person have a cognitive disorder of some sort? Intellectual impairments. That's the first thing we look at. Does that person have functional issues? Adaptive functioning. Can they read? Can they write? Can they manage their self-care, their finance, and so on? Things we're very attuned to. And then we ask the question, does this stuff that we see originate from the developmental period? That's really the question we're asking. We're not asking whether that person has autism or not. We're not asking whether that person has a brain injury or not. We want to see how their brain functioning is actually doing and how it was doing before the age of 18. So it's very broad. The primary care field has a hard time with that because when they look at individuals, they look at autism, they look at schizophrenia, they look at brain injury, they look at diagnosis, but not necessarily the person's functioning. So intellectual disability or developmental disability is very different in that sense. And now that we've shed light on it, people are realizing, well, oh, I have so many people on my caseload that meet the criteria for this. So it's actually just doing the project was informative because now I was in a meeting with Karen Chan at the DSO a couple months ago, and she said, maybe you're the cause of the people referring to, like we're in the shelters and so on, because she felt that she saw an influx of individuals being referred for assessments and diagnosis, and we were certainly pushing a lot of people, folks through the system. So that by itself was very, very good. And I must just make a note that it differs from brain injury in adulthood or dementia. So as neuropsychologists, we have to do our effort to really tease that apart, and sometimes that's not easy. I'm going to skip about that because you guys all know this slide. The system is, like in Ontario, every hospital clinic works through a referral-based program. And at the chagrin of my colleagues, I criticize that model for a number of reasons. First, it's clunky. It's, and I basically, it's the best image I could find for it. We create wait lists. We're not responsive. We don't get to people very quickly, and sometimes people get referred to us for inappropriate reasons. So as a neuropsychologist, every time you refer to me, I have to do my due diligence. They get a full assessments. We do a full interview. We order records. That process can be about 20 to 25 hours per patient. So if I'm the only neuropsychologist working in the shelter system, there's a huge problem here because I still have to, every patient comes in, whether they have a developmental disability or dementia or brain injury or not, I still have to do the work. So I'm building up a wait list. And before Bridges to Housing, my wait list in the shelter system was always hovering around 100. So by the time I get to the 100 person, that person had died. Or like so, I had more people drop off my wait list because they died than because I was actually getting to them. So the system was flawed, it wasn't working. And I have the same issue at CAMH, where I'm supposed to, I'm the neuropsychologist for CAMH, and I have a huge wait list internally, and then I get to them, you know, they're discharged, they're gone, so, or they might not need the assessment anymore, so we're not responsive enough. What we started doing in a shelter is like, how can we change that? How can we have a population-focused approach of screening and triage, so we can get at people much more effectively? And we piloted that in a few shelters where we go in for one day, we meet the teams, we go through caseloads, and we basically set up the definition, what we're actually looking for. We're educating about brain injury, about developmental disability, about dementia. We're setting the stage for people to start thinking differently about their clients. And then we go through the entire caseload. So we go to staff meetings. So within a staff meeting of 1 hour, we can go through 100 patients. And basically from there, we just have enough evidence to get the ball rolling. So we rule out 75% of the population that doesn't need an assessment, and we own in on the 25% that does. And then we bring in a psychologist, bedside assessments. We do screening with them. So instead of waiting 6 months to 2 years to see a psychologist, we just bring the psychologist to the teams. And if we have 3 psychologists, we do 20 neuropsych assessments in one day. So we just do that for a week, and we get through get through everybody. So we do a full interview, we do some limited cognitive testing, but just enough to get a glimpse of whether this is a DD or not. Should we engage in the full assessment, or what we call the eligibility assessment, or not? And when we compare to business as usual in the developmental service world, where a person might wait 6 months to 2 years to get in DSO, we got it down to 3 weeks. So we go into shelters, we identify folks. There's still hit and misses, but I'm not clogged up anymore. I don't have wait lists. We go in and we do everybody right away. And once we identify somebody with a developmental disability or brain injury, whatever issue they have, we send them the right pathway. So if it's DSO, we have a DSO staff on our team as well. So after I'm done my neuropsych assessment, the next day she comes in and does the what they call the ADSS, and assist assessment. And so within a week or two, all the process is done. People are admitted in DSO, and then we can start putting them on wait list for the DSO passport funding. And passport funding for us, for the homeless, because the priority got down to about 2 months. So within 2 or 3 months, we got them connected with a caseworker. We get them connected with passport funding. We get them connected with all this stuff. So we've managed to get not only the psychological assessment, which a lot of people are frustrated about because we're not nowhere to be found in the public system, to getting everything done. So how can we actually now expand this to the rest of the province? And that's the biggest question. So in a nutshell here, and somebody's going to wave me for time, right? Eventually, I hope so. So this is our model. Essentially, instead of having a clinic at CAMH where I get 100 referrals a year, 200 to get things like where it's clunky, we basically go in, and we go in hospitals, we go in shelters, wherever there's a team, we go there and we initiate the triage. And we really and you guys have the triage tool in your package as well, and we set the stage. And then we go and do screening, diagnostics, and then we push them through the screen. So if they have ABI, we send them right away to the ABI network. And it's working really well. Here are some, actually, for developmental disability, for the homeless, some quick statistics. There's about 5,000 people in the city right now who are using shelters. And a lot more folks around that are actually at risk of homelessness. And we have rates of about 18% suspected rates of developmental disabilities right now. So we went through 7 shelters, and this is the number we're getting. All of these individuals get a neuropsych assessment. So, and when we go in, sometimes we find out, no, it's more of a dementia than an intellectual, or more brain injury, and so on. We have to make that differential, but by far not, like, we are finding a lot of folks now who have developmental disability, who fell through the cracks, so the parents have died, or something happened, whatever resources were in place to protect them, it failed, and they ended up being homeless. Some individuals have actually been homeless for a decade or more, and we haven't got to them yet. We also look at their, during triage, we actually look at, when we look at all those who are suspected of developmental disability, we break that down a little more. And 13% of those with DD require a managed alcohol program. That's not available in the DD world. So where we actually serve alcohol as a way to help them prevent further harm. And rule breaking, drug smoking, and we call that from a housing perspective, right? If somebody smokes, they usually lose their housing, or if they drink and so on. So rule breaking in that sense, from a housing perspective, we're dealing with 50% of those with developmental disabilities will engage in rule breaking behavior and get evicted. And it's big, right? ER visits, 20% roughly of the folks we see with developmental disabilities are high ER visitors. So they will use the ER more than 10 times a month. That's a lot of, that's very costly. Housing needs, we broke it down in 5 levels, but essentially there's either they're independent, that they could, we have, from the best knowledge we have, 7% would actually be able to live independently if given housing. 25% could get housed with supports. The ACT teams, case management kind of led, could be mild to heavy case management. But the reality is 68% of those suspected developmental disability require 24-hour care, 24-hour support. Where am I going to find that, right? That's not really exists. It's already hard enough within the DD world to find housing for folks. I'm about to add 500 individuals from Toronto with severe needs to the wait list, and there's no supports to be needed. And when we break that down, 25% of, or the 68% basically, require intensive behavioral supports. You know, a subset, 11%, require nursing support, so medical supports, and then about 30% of that number basically require some sort of presence in the environment. So they could live relatively independent if they have some sort of presence in the environment, make sure that they, you know, they take their medications as prescribed and so on. And then when we looked at the profile of the actual person, this was last summer now, my data is about to be updated, but the first 26 persons we pushed through the Developmental Service Ontario, a lot more were male, but we could, right away we knew that their IQ was markedly impaired, like below the second percentile in terms of cognitive functioning. The majority of them can actually recognize basic emotions, so social cognition, so navigating the social world, they were impaired in that. Adaptive functioning was impaired across the board. So, and we also looked at incarceration, abuse in childhood, TBIs, mental health issues, and so on. And mental health issue, 92%, so basically they would qualify as dual diagnosis, had number of mental health issues. Abuse in childhood, 75% of the females that we saw reported severe abuse in childhood. And that's the first time we've met them. I actually think it's an underrepresentation because a lot of time, who are you? I'm not going to disclose that information to you, but nevertheless, 75% of the people we saw, women we saw, disclosed it right off the bat that they had severe abuse. And then for the males, a bit lower, but again, 46, close to 50% mark, on the first visit, they disclosed that they had severe abuse or neglect in childhood. And I would expect that number to go up, but still, right, just based on one interview with the patient, this is what we're getting. Drug use and so on, traumatic brain injuries. Half the individuals we saw with developmental disability had an overlaid brain injury in adulthood, causing even more disability. So because you're on the streets, you're prone to abuse, you're vulnerable, you get taken advantage of. You know, it's easy, like all the cases, like sometimes I've had one patient who was hit in the head with a fire extinguisher at nighttime in the shelter in Toronto. So there's a lot of violence that can happen, and he was, you know, hospitalization, ERs. The crazy stories I'm hearing, it's mind-boggling. So this is our improved, again, probably in your package, this is our improved pathway to DSO now. So instead of waiting 6 months or 2 years, this is we're actually going to be meeting with, Jen is going to be with me tomorrow. We're going to be meeting with Karen Chan and MCSS to see how we can replicate this access, this program a little bit more effectively and include transitional housing in it as well. So this is moving forward. So we've got like, the one thing I'm just going to focus on right now in terms of achievement, just by really thinking through the issues, is the wait time. So getting everything down to 3 weeks for me is actually pretty good. And from a homelessness perspective, and you know, you're accessing your psychologist, and then beyond that, accessing DSO resources, I think it's a huge win. But I think we need to start thinking more holistically. How do we actually provide that across the board to all individuals with developmental disabilities, so we get screened them a lot earlier? Because I thought the school system would pick them up, but the reality is that if I'm finding them in the homeless shelters, somebody has not picked them up somewhere. And I think there's a lot of those individuals out there who have never been picked up before that just basically hovered their way into shelters. A quick look at CAMH before I move on to the actual things we can actually do and to help along. I'm going through all the inpatient units at CAMH right now, looking at all the ALC teams and trying to figure out what's going on. How many individuals have developmental disabilities? How many have dementia and so on? And why are they there? Why am I finding individuals at CAMH for 10 years? And we're going to go do this and find out at the end what's going on. And right now with DD, when we interviewed a team psychiatrist, they're telling me about 31% of folks in inpatient in ALCs have developmental disability. And when you add, you know, the rule-outs where they're just not unsure, they think there might be something there, that we're close 40% here. And we're going to do this work at the Royal in Ottawa. We're going to start doing shelters there. We're going to go to Thunder Bay. We're going to go to Kenora. We're going to start thinking more broadly now how we can expand these kind of perspectives and efforts to more teams across the province. one of the things that was made clear to me is from a Native perspective, Aboriginal perspective, from my colleagues who work in Native reserves. There's a psychologist actually does a lot of work with kids, and she was telling 30-40% rates of FASD in some of these Native reserves that have not yet been connected to the services. So how do we go about and creating a program that's culture sensitive, but also unlocks these resources that are much needed earlier on? We have a lot of things to do on our to-do list. I think, generally speaking, behavioral therapists are not very available, and we need more of them. Occupational therapists is one of the big things I'm advocating for right now. I'm still, after 4 years at the family health team, I'm still, holding my breath for an OT and BT to come in and be helping out with some of these clients. Not going very fast. Ministry of Health is not the fastest responsive ministry out there. You think MCSS is bad? They start dealing with health. And it's so big and massive, I understand, but at the same time, you think that we get that piece covered. And the reality is, psychologists in a province is still private, right? We have more psychologists in Ontario than there are psychiatrists in Canada, but yet most of them are working in private clinics because it's not covered by health. So I work in the family health in CAMH, but I'm the only one in the family health team network in a province doing neuropsych right now and doing this kind of work. So it's frustrating because I get referrals from all different shelters, different organizations, because I'm public, but I'm the only one, so my wait list gets bigger. And so I'm trying to innovate with what I have, but at the same time, I think one of my asks from government is start investing in your behavioral therapists and your OTs and your psychologists, because we need them in your interdisciplinary teams to help out the nurses and social workers and so on. So we have to start becoming a lot more interdisciplinary focused in teams. And now the what you can do part, that's probably the things that you might be more interested about, because I'm not sure if this interests you at all, but there are certainly some things. From my understanding, most of you are working directly with clients who have developmental disabilities. Am I correct? Yes? So, and there's some people from the mental health arena, others from the developmental arena, and so on. Am I correct in assuming that as well? So some folks in the mental health stream might not know so much what's happening in the DD world and vice versa. Again, maybe you're a different crowd because you're already here together, which is phenomenal. I wish I see that more often. But there are some things you could do in the front lines, certainly to help the triage and diagnostic pathways. So are you dealing with a developmental disability or not? And what can you do to find out if you're dealing with somebody who has not been diagnosed yet, but you strongly suspect? So if you work with a given population, you start having instincts and you start to pick up on things, but is there something you can actually do to kind of figure out what's going on? And if I'm struggling with the physicians I'm working with to work on the screening and diagnostic part, I think you'll probably have a lot of issues out there trying to educate other workers, clinicians about developmental disabilities. So there's a few tools out there. One of them that I printed it's a tool out of UK that basically has 7 questions. And they call it learning disability out there, but it's just, we're talking about the same thing. It is a developmental disability. And one of the things they found is if a person can't tell time well, that could be a sign that there's something developmental going on. And again, this is not diagnosis, it's just more about highlighting and screening. Can a person read and write? What we refer to as functional academics, and that's usually a big indication. And is there, did they go to school? Did they get special education classes and so on? So as somebody works directly with clients that has not been identified yet as a developmental disability, these are a lot of the questions you could start asking. And functionally, can the person live independently? Can they have a job? Again, this is not diagnosis, but it should help you start to think, well, maybe we're dealing with something with a developmental disability. And if you have that pre-18 element, so has the person been struggling in school? Has the person, had needed special ed class? Now, that doesn't mean they have a developmental disability, but it's a factor that cues us to think more about, okay, this individual might need an assessment to really figure this out. If you, and I had physicians who were referring people to me with, they have a bachelor's degree, and they had average grades and so on, and they're doing poor cognitively now, but they get referred to me as developmental disability. No, because you know that whatever happened in adulthood. It's likely more of a brain injury or severe mental illness or a dementing process. Wait, don't, but I still get those referrals. So I think there's a lot of work we need to do in the primary care teams to educate the physicians and nurses about what is a developmental disability. Again, it's clogging the system. But this is definitely something in the front lines. If you're in the mental health world in particular, working with the CAMHs of the world, the CMHAs of the world, and you have caseloads, ACT teams, these are something. This is the lens you need to have to actually see if there's something there. Traumatic brain injury. Anybody here deal with traumatic brain injury? A few folks as well. What is traumatic brain injury, right? What's the definition? If you had that, what is the impact on functioning? There's screenings out there as well that you can look at, and this is a good one. It's in your packet as well. Not a diagnostic tool again, but it's there to really help you focus on potential events in the person's lives that affect their functioning. TBI, they have a nice acronym, the trauma, the injury itself, the behavioral effect immediately, and the impact on everyday function. Not all traumatic brain injuries will result in functioning issues. So what we refer to as mild traumatic brain injury in isolation, typically that resolves itself. If you're in school and you have kids in school who play sports, they get a whack to the head, the recommended thing we'll do now is let's pull them out for a few weeks, even withdraw them for school completely for a few weeks until they recover. Because if we put them back in play, or if we put them back in classroom, that could actually slow down the recovery process. So anybody who has kids here in the room, you should know that if your child has had an injury of some sort, or if the young clients are working at an injury of some sort, let their brain heal before you put them back in classes. Because when you're back in classes, what does the brain need? A lot of sugar, a lot of oxygen, and so you're asking the brain to process new information and learn what they're supposed to be in school, but the brain is still healing, requiring tons of energy to heal. So when you force the person to actually learn and think, you're depriving the brain of the resources it needs to heal itself. So when we think let's put them back in play or put them back at school, we're actually harming the child more. It might take them, instead of taking them 1 month to heal, it might take them 3 months to heal. So these are new things coming out now in the sports injury world, but how can you actually label somebody as brain injury? It's not everybody who actually deals with that, and frankly all the patients I see had tons of brain injuries, but nobody's asking about it. And when we actually start digging, we can actually see the point in time where things went off the rails. That one time he got hit in the head with a baseball bat, or that one time in the head he got a car accident, and everything went downhill after that. So this is a tool you could use with your patients and basically go through it, because you ask things differently. If you ask somebody if they have a traumatic brain injury, they'll say no, because it won't come. But then when you start asking, did you ever have a bike accident when you were a kid? Did you ever hit your head? Did you ever lose consciousness? And when you did, do you remember what happened right before that or right after? These are all actually signs of what the severity of the injury. So if the person tells you, like that woman I talked about, the 7-year-old, I asked, do you remember actually falling off the piers? No. It's somebody had told her that. She doesn't even remember that day. She doesn't even remember she went to the piers in the first place. This is what we call post-traumatic amnesia. Basically, before the injury, after injury. How much do you remember? What's the first thing you remember when you came out of your, came back from losing consciousness? Do you remember the hospital stay? Do you remember the ambulance? And sometimes people have no memory for 3 weeks after an injury. That's a pretty severe injury. And if we look at these individuals, they will tend to perform more functionally poorer afterwards. They won't be able to go back to work as easily anymore. They will need a lot of scaffolding to make sure they can move forward. So this is a tool I would recommend you look at and use with your clients. And we're going to practice some of these. So I'm going to test your cognitive abilities today. We're going to go around the rooms. And how much time do I have, Jen?
15 minutes.
15 minutes. That's enough time to stress you guys out a little bit more. The MOCA is called the Montreal Cognitive Assessment. It's a screening tool that you can download online. It's usually a tool that physicians and nurses will use to screen for cognitive disorders. But it's a tool that, if you can't access a psychologist, you can't access a physician really easily, this is a tool you can download yourself, and we can be trained to administer it. So if you work with nurses and social workers and so on, these are tools that you can learn to start administering better to figure out if they are dealing with a cognitive disorder. And in the shelter system, I'm actually training frontline staff now to do this. So I want to make sure that before they refer to me, they actually know what they're talking about. So the first one, is it in your packages? Yeah, there's some mochas in there.
So those are on tables, but we didn't have enough of that one for everyone. So if you have a table that has extras, can you raise your hand?
So okay. I'll start picking on table 2 here because they have a lot of mochas. And I think the first thing we can actually do together, everybody at the table, and just so you can put yourself in your patient's shoes for a second, is the first 3 items you can do by yourself. So the first one is, you have to connect numbers and letters, so in ascending order. So take your pen right now and connect the numbers and letters in ascending order. So 1 to A to 2, 2, and then you go on. And I'll give you a second to do that. So you start basically here, you would start at 1, go to A to 2, and you move on alphabetically and numerically in ascending order until you finish. Not always an easy task. So,
Sylvan, someone said they're worried about like messing the sheet up. We'll make sure you guys get copies. We can email you copies so you can borrow this one.
It's free.
Yeah.
You can download all you want. And what this test does, it actually looks at all or most of the brain's functions. So the first test that you just did, most of you will do that pretty easily. And if you can't do it, just don't tell me. We'll pretend it's not there. But it's really a test where we want to measure somebody's ability. It's an executive task, what we call executive functioning, that looks at mental flexibility. Some individuals with brain injuries do very poorly on that. They struggle with that. And if they struggle on the screening task, that means they will struggle a lot in that aspect of their life. The second one is a cube. Can you make a copy of the cube, please? Try to make an exact copy of that cube. Never again will you ever invite a neuropsychologist at speaking at your conferences, eh? You have to think, right? And why is a cube important? Why am I making you draw a cube? It's something we call visual construction. It requires multiple things. We have to actually see the item, integrate it in your mind, and then reproduce it. So you're using motor skills, you're using your attention, you're using your occipital cortex and your parietal cortex, part of your brain, to actually reason. And the last one I'm going to let you guys do here is that clock. Can anybody here draw me a clock? And set the time to 10 past 11. So in that square box at the top right, draw me a clock from memory without looking at your watches, please. Because my patients cheat all the time. I have to take off the clocks from my room. Yeah, the kids, believe it or not, the kids I'm seeing, they're a little clever. And sometimes they draw me a digital clock, which I have to actually, and so believe it or not, the test won't be valid for much longer because the kids don't really see clocks anymore, right? So it's too bad. Neuropsychologically speaking, it's a very informative task. Individuals who can't draw a clock shouldn't be driving. Individuals who can't draw a clock, you have to start thinking, how bad can actually get in your brain that you can't actually perceive information, integrate it, and produce it out of memory. So there's a lot of, there was an occupational therapist who did a nice study recently about the correlation between driving abilities and the clock, and found a high correlation. So if you have a client who can't draw a clock, they probably should not be driving. So we have to suspect if there's a brain injury or dementia going on at the point in time. So who here did a clock and had trouble with it? And there's a few, nobody's gonna raise their hands. I can't pick on you. All right, somebody who did well with their clock. Let's start with there. Can I pick one sheet? Oh, that's a beautiful clock here. All right, I'm gonna use this. So they have to draw a circle. I'm not gonna put it on the stage, okay. So you have to draw a circle, right? Believe it or not, if you have a traumatic brain injury and you hit part of your brain, the right or the left, sometimes what they will produce is half a circle or a squished circle. Sometimes, so they might neglect an aspect of it as well. And so sometimes if you've been, most people are right-handed, if you get hit to the right side of your brain, the parietal cortex right here, you might lose the ability to draw a clock, to have the big picture representation of the world. And you might neglect half of it. So you might start neglecting half your world. So something called neglect. And if you see a patient who is bumping into things and stuff like that, and they had a brain injury, it's a good quick test anybody can do to figure out if there's something neurological. It's actually one of the most popular tests that neurologists, neuropsychiatrists, and neuropsychologists will use to figure out if something has a brain-based disorder, a clock. So I'll move on from that. The other 3 animals you see, it's a naming test. Can everybody name those animals? It's very simple. Culture sensitive, of course. We like some, if you have had some individuals who've never been exposed to these animals before, I'm not going to diagnose them with a naming disorder or some like an aphasia of some sort. But if they're from Canada, if they're from North America, these are items that are very common in people's visual lexicon. But when you can't name those basic items, I start to wonder about your left temporal lobes, basically, because naming should be not automatic for people. So again, it's a big sign. Most people will actually pass those 3, but if you don't, you probably have something going on with your left temporal lobe. Is it something called primary progressive aphasia, which is again a type of dementia, the brain affecting the temporal lobes. So we have to start figuring out what's going on. And if you move forward, memory. So basically, in this case here, I can't do it with you guys, but repeat the word a few times, and then ask the client to basically repeat them once, twice. That's learning, verbal learning. Can they do that or not? And then, I don't tell them this, but I'm going to actually test the memory later on. So a few minutes later, near the end of the test, do you remember those words that we learned together? And it's kind of what we call incidental memory. It's not best memory test, but if you start failing those items very short, and you miss a number of items after a few minutes, I start to wonder, is your memory actually okay? And most people will miss 1, but if you miss 3 or 4, something's going on here. Because is it that you are not paying attention to begin with, or is it because you have a difficulty with encoding information in your brain and recalling it? Again, this is if you have patients who have memory difficulties, or they tell you they have memory issues, this is a little test you can do. And again, language abstraction. Can you basically, there's other ones that test working memory, so we'll give you numbers and ask you to repeat them backwards. So if I say 742, can you tell me that in reverse order? You know, it's 3 items. Most people have a decent digit span. 247, but patients oftentimes can't do that because they can't hold information online long enough, and that could be a disabling. So when you start adding all these cognitive functions together, and they might have a poor score up together. So now we're starting to think maybe it is a developmental disability, maybe it is a brain injury, or maybe it is dementia, because all 3 are neurocognitive disorders by definition. So this is a tool. You can have objective data on a client's functioning at your disposal, at your fingertips, to figure out what you're dealing with. So anybody who comes in with this in my office gets a lot of kudos. If I can give chocolate bars to everybody who comes in with a mocha, it's great, because then I have baseline information. You're telling me that the person's not doing well. I have to rely on the fact that you've learned to administer tests appropriately, but ultimately it gives me an indication. So if I have 2 or 3 mochas in different time plans, I can see if there's decline in functioning. Then I can strongly suggest a dementing process. So if you have 5 minutes left, excellent. If I have 2 hours, I can't skip lunch. Yeah. The last one. So, and that brings us to what I do now to change the systems approach to things. It's the RARS, and I believe it's in your toolkit as well. I'm hoping, if not, well, I'll give you copies. It might have been just in my copy, but it's the questions that I tell the nurse working in her team to go in the teams and ask those questions. There's basically 10 to 15 questions. We set the stage. Basically, what I did with you today. I do this in every team I go to. We define developmental disability. We talk about dementia, what it is. We talk about brain injury, what it is. And then, we kind of give them a new pair of glasses, and they see the world differently, and they start seeing their caseloads differently, and you go through them, and then you start answering questions about their functioning, about their abilities, and whether or not you suspect it's a dementing illness or not. And at CAMH, it's changed the way we're practicing because we go in units. We're not waiting for this, you know, the teams are all different. We have great teams at CAMH, we get referrals all the time, but we have teams that I've never heard about before. And when I went, I'm not going to label a team because if there's somebody from CAMH here, I'm going to get myself in trouble. But I went in that team and found rates of 20%, but yet I never received a referral for them. So the referral system is flawed. So the patients will benefit only if you are on top of it. As frontline workers, as physicians, as nurses, if you know the issues and you know the systems, your patients will be lucky. But half the teams out there are not as lucky as you are. So patients get undiagnosed, they get unidentified, and they get worse. Sometimes I see people with dementia. They're getting worse in a shelter. They need palliative care. But we could have delayed that if they had access to Baycrest, for example. And they have a great memory program. They have so if we diagnose somebody when they have pre-dementia, what we call, I guess it doesn't matter at this point. So basically, 5 years before we actually diagnose dementia, there are signs. And we can actually start doing rehabilitation early on to delay the inevitable. So instead of having 5 years, you know, we might be able to give somebody 8 years, 9 years of good quality of life if we do it properly. Brain injury, same thing. We could, if we start intervening right away in somebody's life after they had a traumatic brain injury, once they're stabilized, we can improve the cognitive functioning and their ability to go back to whatever lives they had before, if possible. But if we don't, again, that person will be at a loss. Had a patient, that's probably the last example I'm going to give you, who was sent to St. Mike's with a traumatic brain injury, had what we call the right frontal subdural hematoma, nice fancy words. Basically that your brain is damaged and there's a bleed inside the brain. So they did what we call the craniotomy. They did what you need to do to keep that person alive. They evacuated the blood, they stabilized the person. 3 weeks later, that person was discharged. However, where the system failed there is that person should have been sent to TRI, Toronto Rehabilitation Hospital, for rehabilitation. But because that person was homeless, there was nobody advocating for that one. And he ended back at the shelter system and never received the rehabilitation that that person should have needed because they were homeless. So a lot of the folks I work with don't have anybody to advocate for them and they fall through the cracks. If any of us here, because we have family members who care for us, who are there supporting us, if something happens to us, I can guarantee everybody, if you have a child, you will advocate for that person beyond belief. And in our system right now, those who are louder, advocate more effectively, get better care than those who do not. That's not equitable. It's not a good system. And I think we need to start working at that because a lot of, if you know all these things and you know the system, your patients will have the best care possible in this province. And it's way better than if you go to other places, but I think it could even be a fairer system, a more equitable system. And I think my time is running out. I'll leave some questions, but I'll leave my email address at the end. If you want to talk, email about anything, I'll be available. And if you have questions now, I'd be happy to answer any of your questions. Who's first? Yes.
Wait, Mike, you need the mic.
Just a quick question. You were saying that affordable housing is not one of the main factors. If you think as much money, because we're spending a lot of money in affordable housing, do you think if as much money was devoted to treatment in the province and in Canada, that would ease the burden on the shelters and the homelessness? And the second part of the question, cities like New York and Chicago, who've claimed over the last 15 years to be getting a lot of people off the street, cost of housing in those cities, large urban centers like Toronto is very expensive, they have dynamic problems. Have you studied that to see what kind of models have worked there, and is that possible to implement here?
It is possible. I think what you're referring to is definitely what we call the housing first approach. It's been a very cost-effective model in the States, and the idea behind that is we provide the housing and then we deal with the things in parallel. We don't try to provide rehabilitation and then when you're ready we give you housing. We just basically, we need a place where we could give housing to people, good housing, adequate housing, that meets the level of need, and then we provide the care there. What we have in Toronto is we have a housing first approach, but without the care. So people end up coming back to the shelter system. So we have half the solution. So, and especially when we're starting dealing with folks who have complex health issues, seizure disorders, cognitive disorders, or they're having dementia. When long-term care is not available because you drink or you smoke, but you should be in long-term care, what happens? There's catastrophes happen. When one patient that was housed ended up setting fire to the place, he was living in a basement apartment. He forgot to turn off the stove. It was the wrong housing for that person. He had a severe memory impairment, and it was destructible. And he was not a bad guy, but he had a lot of common issues. We put him in a basement apartment. Nobody wants hurt, but if it was an evening time when there's kids in the house, we need to start thinking through housing. So there's a costing element to your question as well. So we need to provide the right housing at the right time. We need to provide the right layer of service as well. So if you have behavioral challenges, behavioral analysis works great. There's more we can do than just simply medicating people. I think people can learn to maximize their function in whatever environment they are, but that's not provided here in Toronto. You're not lucky. Some people are lucky, others are not. It's not a fair system. And the other part of your question was the financial element. So Toronto, it's true that New York and some cities in the state claim that end homelessness. I'm skeptical about whether they got the whole rate, but Housing First, in theory, should work for at least 80% of the population.
Oh, but like you said, how much of it is a system failure?
Mm-hmm.
And I know the police do good work, but I know a lot of our people, because of the city bylaws in Toronto, they're very strict. So if somebody, let's say, can't be in a shelter in the street, police will. Like, how much of that do you attribute to this? I know
lack
you
of
said a lot.
response
The
versus
system,
the
the lack of the systems working together.
Mm-hmm.
Can we frame that for
Sorry.
people who have a question?
Sorry, the lack of systems. Yeah.
So,
Just a systems thing.
so I think there's two parts to the answer. The first part is if we work together and instead of being in silos, the police system, the hospital system, and so on, how much could we achieve into promoting stability and so on, and saving money, and address the housing issue? I think that's definitely half the battle, because if we don't have the right interconnectedness, the fact that CAMH is not talking to the police or whatever, I'm not.
Is that being done though?
There's some work happening.
Yeah, we gotta move on.
Yeah.
We have to see if there are other questions as well.
And the housing element, I think there's.
Let's chat over them.
Okay.
Okay, maybe we
Sounds
can just
good.
take one more question real quick, but just before lunch here.
That's a good question. It's a question we could spend hours on.
Sorry, just very fast.
Yeah.
So someone who's an adult that has a brain injury, I had already a case. It was not detected, but by himself. A year later, there was no doctor helping.
Yeah.
And then this person, how do they get referred to, for example, DSTO? How do they start?
Okay. So if you have a brain injury in adulthood, that won't be a DSO referral. That would probably be more of a Toronto ABI network referral. So if you have an injury after the age of 18, that's brain injured, there's a bunch of hospitals and clinics that work in collaboration providing care and services to these individuals. So one agency comes to mind is CHEERS, Community Head Injury Resource Services of Toronto. They have a day program and so on. Where things are complex is if you don't have an ambulance report that documents the brain injury, or if you don't have a neurologist or physician report or something, ER visit, a lot of people slip, hit their heads, they're unconscious for half an hour, they wake up, have a massive headache, go home, go to sleep, and then they go on, but they have issues. So we've started to have a program against homelessness focus where we go on self-report. So we go through this questionnaire with them and document, was there post-traumatic amnesia, was there loss of consciousness? And then what we do is then the neuropsychologist, at least what we do is we document on that for the patient. And then with the neuropsych report, they would have access to the ABI network. So for the ABI network, you need proof of some sort, right? You need a CT scan, you need a paramedics report, anything that documents about a brain injury. And if all else fails, the neuropsychologist can do that as well. So if you've missed, somebody didn't go to ER, I see that oftentimes. There's a lot of signs that when we do neuropsych testing, we pick up, like can't do a clock, they might have weakness in one arm or the other. We pick that up, and then based on that information, we can send people along. But it's accessing those. So St. Mike's Brain Injury Clinic is a place that you can ask questions about. They have some staff there that could help with that process. Getting physicians to refer to neurology, to neuropsychology. Again, you have to work with the primary care, I think, the physicians, but that's going to be, it's a hard one, it's possible, but it starts with you, I think.
So the first place to go is San Mike's, the injury clinic?
Mike's is a good one, or the family physician. Whoever's, if it did not work.
Okay. Sorry,
And another question to talk about afterwards. All right,
yes,
so.
okay. So I don't mean to interrupt and cut off. Maybe if there's a moment after that she could connect with you and maybe get some more information around that. Great discussions, great questions. Thank you very much, Dr. Roy.